Have you ever wondered why two patients with the exact same diagnosis can take the exact same medication and yet have completely different responses? For decades, medicine has essentially grouped diseases by the organ they affect, right? We treat the joint, we treat the skin, the gut. But what if your diagnosis was actually just a broad, kind of imperfect label? What if the real cure was hidden deep inside your unique molecular pathways? Welcome, everyone, to this explainer. I'm absolutely thrilled to guide you through this material today because, honestly, we are looking at some groundbreaking research straight out of the Eular 2026 conference. We're talking about a complete paradigm shift here. We are moving away from all that old guesswork and heading straight toward high-definition, pathway-driven precision medicine. It's a real game changer. So, to help us digest all this research, we're going to follow 6 key pillars today. We'll start with the precision medicine shift, then move into upgrading our diagnostic tools, ending trial and error therapy, dissecting difficult-to-treat disease, the nuances of remission, and finally, smarter long-term safety.
All right, let's jump right into Section 1, the precision medicine shift, redefining diseases by biology. Historically, treating a complex immune condition was, it was kind of like throwing darts blindfolded. Doctors had to rely on empirical trial and error based on really broad symptom labels. But now, massive genetic analyses across 16 different inflammatory diseases have proven that diseases actually group together along shared molecular pathways. We're finally shifting from throwing darts in the dark to biology-guided, GPS-targeted therapy.
The researchers concluded something absolutely profound here. They found that pathway-level genetics, not organ-level diagnosis, defines the cluster. Meaning, conditions that look totally different in the clinic, like, say, rheumatoid arthritis versus psoriatic arthritis, actually share the exact same genetic core. Specifically, they share alpha-beta T-cell activation. So you might have 2 totally different symptoms, but identical molecular risk.
Moving on to Section 2, upgrading our diagnostic tools, high-definition biology.
Now, to actually target these specific pathways, we really have to expose the limitations of our legacy tools. For years, clinicians leaned heavily on the ESR. But let's be honest, ESR is a blurry, slow marker, and it's easily thrown off by things like age or anemia. The research points to a much sharper alternative, the albumin to globulin, or AG ratio. It captures this highly dynamic range of systemic inflammation, and it brilliantly maintains its accuracy precisely when ESR fails. But, we aren't just looking at routine chemistry anymore. The research highlights a truly fascinating biomarker called serum calprotectin. While standard markers primarily track liver-driven inflammation, calprotectin is actually released directly by activated immune cells. It tracks the specific cellular axis. It's an incredible leading indicator that helps doctors see if residual joint pain is coming from true hidden inflammation or if it's just old damage. And speaking of hidden conditions, get a load of this staggering statistic: 61.2%. Over 60% of non-obese rheumatoid arthritis patients were found to have subclinical fatty liver disease, and this was even with low joint disease activity. A specific atherogenic signature was revealed in these patients, completely proving that systemic inflammation goes way beyond the joints and actively amplifies cardiovascular risk. Which brings us to our next major diagnostic leap, RAMRIC. This is a fully automated AI MRI pipeline. Since the symptomatic phase of arthritis is often preceded by literally years of silent biological activity, this AI was applied to at-risk individuals. And guess what? It detected hidden tissue inflammation years before clinical arthritis actually strikes. That gives us a vital, unprecedented window for early prevention. Okay, Section 3, ending trial and error therapy, molecular treatment signatures. So a blood-based classifier developed by Cipher Medicine, known as the MTRS, is completely changing the game. This classifier integrates transcriptomics right alongside genetics and clinical data. And the results? Patients selected by this classifier experience roughly double the clinical response rate, meaning a 50% or greater improvement in symptoms when given T-cell targeted therapies. It actually captures baseline activation to predict exactly who is going to respond. Similarly, researchers developed a functional assay that measures ex vivo signaling. So instead of standard markers, they measure the actual IL-6-driven signaling intensity inside the patient's cells in real time. Notice how high baseline IL-6 activation tracks with a much stronger response to IL-6 blockers, while a broader activation pattern pairs much better with JAK inhibitors. We are literally matching the specific drug to the cell's real-time behavior. Let's shift to Section 4, dissecting difficult-to-treat disease,
beyond the label. When standard therapies fail, a registry analysis breaks difficult-to-treat disease into three distinct drivers. First, comorbidity burden, which surprisingly is actually the strongest contributor. Then, established structural damage, and finally, persistent disease activity. This tells us loud and clear that mindlessly cycling through expensive biologics will absolutely not fix structural damage or a comorbidity like obesity. Refractory disease requires very specific, access-directed interventions.
This becomes even clearer when we look at actual tissue biopsies. Researchers are now able to match specific tissue biology directly to a patient's history of treatment failure. They discovered these highly distinct pathotypes, like a myeloid-rich pathotype in patients failing IL-6 therapies and a lymphoid-rich signature in patients refractory to TNF inhibitors. We can finally say to a patient, hey, your tissue looks exactly like this, so you need exactly this mechanism next.
The overarching takeaway here really shatters an old clinical assumption. Difficult-to-treat disease isn't mostly just non-inflammatory damage. The research explicitly states that active synovitis, complete with heavy cellular infiltration, persists in the vast majority of these biopsies. These patients still desperately need immunomodulation, but it absolutely demands precise, pathotype-guided intervention.
Moving to Section 5, the nuances of remission, defining the target. Imagine a clinician reports a massive success rate with a drug like baricitinib. You'd probably think the patient is cured, right? Well, it wildly depends on the index they use. The DAS28 criteria is highly lenient, so it yields artificially high remission rates. On the flip side, the stricter Boolean criteria requires near zero tender joints, so it reports much lower rates. It's the exact same patient taking the exact same drug, but with wildly different outcomes purely based on the mathematical criteria being used. The massive discordance between patient questionnaires and objective ultrasound proves that an apparent remission doesn't always equal truly quiescent disease. A patient can easily meet the lenient criteria for remission, while an ultrasound clearly shows active residual joint inflammation that's being left totally unchecked. Stricter targets are absolutely necessary here to prevent long-term damage. And finally, Section 6, smarter long-term safety, precision in practice. When we map out the prolonged use of JAK inhibitors, we realize we've been wrongly thinking of them as one big homogeneous class of drug. There are stark within-class differences here. Tofacitinib shows a distinct herpes zoster signal, while upadacitinib and baricitinib carry much more pronounced cytopenia signals. Crucially, though, the primary modifiable risk factors aren't just the drugs themselves, but concomitant steroid use and the patient's age. Prescribing simply must be subtype dependent.
So, the crucial question we're left with is this. We've journeyed from generic organ labels all the way down to specific molecular pathways. We've seen AI predict disease years in advance, and molecular signatures literally double treatment success. If we can now read the exact biology driving autoimmune disease, are we finally ready as a medical community to treat the true biology instead of the broad clinical label? It is a fascinating future. Thank you so much for joining me for this explainer. Keep questioning the labels and keep learning.